good morning, and welcome to this session sponsored by Rayner on the Rayner EMV intraocular lens. I want to thank all the speakers and the distinguished friends that have been able to join us at this session. Gerd, Auffarth, Detlev, Breyer, Başak, Bostanci, and Allon, Barsam from the United Kingdom, and the discussion panel that will be after the presentations, because they will teach us about the best use and how to manage our patients with this extraordinary lens, which is the Rayner EMV. I want to thank Rayner to put together this session, which is going to be very useful for all the virtual attendance that we have, and I thank every one of you for your time and dedication today. The first talk and the keynote is by Gerd Auffarth, who will talk about Rayner's EMV monofocal, intraocular lenses and RayOne EMV toric intraocular lenses, optical principles and clinical outcomes. And Gerd, this is your time now. Thank you very much.
Ladies and gentlemen, it's a pleasure for me to deliver this keynote lecture on the Rayner's RayOne EMV enhanced monofocal IOLs. In addition, also on the toric version of that. And I would like to explain to you the optical principles and the clinical outcomes. These are my disclosures. Of course, you have to mention here Rayner. And my experience with Rayner is over 20 years now. I actually, already in the early 2000s, I worked with them together. Was a PI for the FDA study on the C-flex and center flex. And Rayner was always kind of innovative and creative with new type of technology. 2003, I implanted the first toric Rayner IOL worldwide. And 2006, the first implantation of a multifocal toric IOL. There were no IOL such as this, and it was a Rayner M-Flex T at that time. The optical principle of reversible trifocality using the Sulcoflex trifocal as a duet implantation with a monofocal lens has been studied by us and introduced already 5 years ago, and then late 2020 and 22, the first implantation of the EMV and EMV toric. And we researched the lenses from all aspects, as you can see, optical bench, clinical work, and so on. And we published quite a bit of publication on the Rayner intraocular lenses over these years. Quite interesting if I look at this now from the backspace. Well, when we look at the Rayner IOL overview, you see here the decision tree, so to say, and the new kids in the blocks are the RayOne EMV and the RayOne EMV toric, as you can see here. In addition, you have the Sulcoflex family and the normal monofocal IOLs, and you can see that in that setup here. Well, the toric lenses and the monofocal lenses are available in 0.5 steps from 10 to 30 diopters, and the toric version goes up to 4.5 diopters with toricity. So it covers quite a bit of patients actually. If you've been to Vienna ESCRS, you could have enjoyed a very nice keynote lecture from Graham Barrett on this technology. You still can see it on the YouTube channel, as you can see here. So he is the father of the EMV technology. So if you have time or you're interested, have a look at this. And he said that the RayOne is a solution that gives the patient best satisfaction without the compromise of losing vision quality. And this is very important because the competitors in that whole area of premium lenses are the diffractive lenses, for example, and this photopsia is a big topic here. So what is EMV? Well, it will increase the range of focus up to 1.5 diopter if you just use the ametropic target. In contrast to diffractive technology, it doesn't create much dysphotopsia or problems with contrast sensitivity, as it doesn't split the light in different areas. You have an enhanced monovision algorithm here, where you can use a specific positive spheric operation design to get a kind of mini monovision approach and get much more out of it than with a normal monofocal IOL. And it's also available as a toric version, and we know from the previous models the RayOne toric platform is an excellent rotationally stable platform. So here you see the difference between a normal a lens with zero spherical aberration, which focused on one spot, and the ones with induced positive spherical aberration, which extends the focal range to up to 1.5 diopters, as you can see here. And it's a very simple principle, and it's unique and patent actually. The other so-called monofocal plus lenses do not apply this kind of technology. So without any light splitting, you get 100% of light distributed over this area. And this positive spherical aberration, which you induce by the intraocular lens, goes along with the positive spherical aberration that you have already in the cornea. And this can actually add the effect, and you may have even better results in some patients, but sometimes it may also be a problem. So it is always advisable to look at the spherical aberration of your cornea. You can use a device like the Pentacam IXL Wave or Tracy or other devices to measure that. The interesting thing is that you can do when you do the monovision or the second eye monovision, use the spreading in both directions of the visual field here on the defocus curve in order to have a maximum area of overlapping. You can see that the RayOne EMV extends the defocus also to the hyperopic side, not like a normal monofocal lens, maybe a little bit to the myopic side, and therefore you have a bigger area of overlapping. When you do that on the optical bench, for example, you see here the defocus with the 1 diopter defocus, which is the dotted line here, and ametropic refraction. And you see already here that you will cover almost 1.5 to 2 diopters of defocus. And you see here with the United States Air Force target how far you can get with the resolution. So, yes, you can see array 1 and 0 diopter and 1 diopter gets you up to 2.5, 2.25. The first clinical cases with a toric lens we already presented last year, and I also published together with Ben Lahoud some of our experiences here. I remember it was in September where we put in the first toric lenses from Rayner in Heidelberg. You see how excited the ladies were when we did that. This case here was, I really have to say, this is a more than perfect case, almost unbelievable case. It's a woman, 64 years old, which had cataract and subcapsular posterior opacification, which also led to quite a bit of difficulties at night and stray light and so on. You see the IOL calculation, you see that she has around 1.5 diopter of astigmatism here. And we used the RayOne EMV toric calculator to do that. Came up with this calculation, as you can see here, the IOL for the right eye and for the left eye. And then we put the lens in. You see here we use the Artevo microscope from Zeiss with the Callisto system. We also used the overlay for the capsulorhexis, so that we had a very nice standard 5mm capsulotomy or 5.5mm capsulotomy, and then the IOL was inserted using the Callisto system to outline the axis in the proper way. First day already we knew that we hit the target. Patient was uncorrected minus 0.4 logma for the right eye and 0 logma for the left eye. Then over time, after 1 week, after 1 month, you see here, for example, after 1 month, the patient really got very good 0 logma or even better binocularly for uncorrected distance, uncorrected intermediate, and uncorrected near 0.04, so full vision. After 3 and 6 months, similar outcome you see here. After 6 months, uncorrected distance acuity was minus 0.24 logma, which is like 1.6 or something in decibel. So excellent outcome. And you can see here the focus curve, which goes very far, even in the minus range, up to 2.5 diopter, and covers almost 4 diopters, as you can see here. Patient was very satisfied, had no further halo, sometimes required spectacle for reading. It was quite interesting because under controlled condition he was like 0.0 to 0.1 logma, but sometimes maybe a little bit dry eye applied here for longer reading. And this is actually very similar to the first implantation that we had in Europe in general. So here are all the firsties, so to say, in different countries. You can see here UK, Poland, Germany, and so on, and the doctors who implanted this. Almost 90 eyes, 56 patients, 16 surgeons, and we have the data here for 1 month's follow-up. And as you can see here, distribution was one third was either mini or modified monovision, and 2/3 were emetropia. You see IOL power distribution here, and you see the outcome, subjective refraction. We hit the target very good, and cylinder also was reduced very nicely. So the refractive outcome was